8 o'clock, and I'm going to start. I am known for selecting topics which are very different than the usual grand round because I'm not a believer in topic presentation. Because I think in this time and age, you can search anything on internet and get it. But I still use internet for this presentation. Anyway, the title is Are we clinically relevant? And you guys will follow what I mean by that by looking at a few slides. So let's on. Okay, so I have no disclosure. I hope one day I will have something to disclose, but I am like all for that. But those who are sitting in the audience or listening to me, try to find something which you can own and you can retire on. So following the presentation, I hope that you guys will understand the clinical guidelines in healthcare, what are the protocol-based clinical care, and how artificial intelligence really can help you in your day-to-day care. So take artificial intelligence as your friend, not a foe. Okay. So just I know that there's a lot of remorse among the younger generation that with AI will take over us. My answer is no, as long as you are wise enough to work with the machine. So this is the slide which is going to be a bit of my talk. So you younger guys, you guys have probably born in all this automated system. When I was traveling first time, it was all manual. You will not believe it. The ticket was issued manually. You have 3 copies, carbon copies. You go to one person, he takes it, and then he sends it to the other station. And now at the airport, we have self-checkouts. Same thing with the bank. You have, you go there, you don't need a human person to guide you. Same thing with shopping. If you prefer, you don't want anyone to really look at your bags or what you're shopping, you can avoid and go to the self checkout. Same thing, I think you guys might have seen that now we have check-ins are there in clinics. You go, you check in with your license, you don't have to do anything. But what I'm proposing, and if somebody can get this idea, steal it, and develop a program and retire early, be my guest. So what is going to happen that you will go to the clinic, the artificial intelligence, you will say your symptoms to the machine will read you, a stethoscope will come out, you put on your chest, the machine will have an otoscope, and then machine will give you a prescription, and next station you get your prescription, and you're all good to go. Is it possible? Self-checkout medicine? Anybody has seen a self-checkout in medicine? Like you go there and the artificial intelligence or a robot look at you and then say, yeah, anybody has seen? Not yet. So see, there's a potential. So those who are interested in developing it further, and again, retiring early, you can go about it. So that is the whole idea about uh, making sure that we still remain politically relevant. We don't want to be a teller in the bank, which after that certain time they can say you're obsolete. Now the machine is doing the job, or a person, a cashier. They said we don't need you because the machine is doing it. So be aware. You have to sell yourself right in medicine too. It's not like nothing is guaranteed. So again, like the question is, are we clinical relevant? And why we have selected the topic of relevance. And these are the 6 domains which all students we teach, all residents we teach. But unfortunately, the last 2 we never touch on. We make you a good person who can take patient care. We can talk about professionalism. You guys have medical knowledge. You pass your steps, and you are guys are good in communication. We work hard to make sure all the blues are covered, but we never work hard on the last part. Anybody know what is practice-based learning and system-based practice? If you don't know, that's fine. It took me a while to learn. So basically, these are the 2 components which nobody teaches you. For example, nobody teaches you in 4th year how to sell yourself and what is the RVU, which job you should take. You end up with a job, you sign the contract, and later on, oh my God, I have given my kidney and liver to this company. And you don't want that. So for that, you have to learn the art of practice-based learning and system-based practice. The other 4, I'm not bothered because you guys are drilled with that. From day one when you join medicine, it's patient care, it's professionalism, people are watching you, there are cameras following you, but the last 2 is up to you. So why I'm saying that, because, you got the younger generation, I keep on quoting that, you guys might be called up-to-date generation. You guys have everything on up-to-date. If I give you a topic, you go to up-to-date give you a nice presentation. If you are nice and smart, you can make your presentation from AI. So these are the 4 areas where I think where we as physicians are really worried about what will happen to us. Are we going to be irrelevant? Because there are guidelines. You ask someone about, oh, the baby has fever, Is the baby 3 months or older? Follow these guidelines from so much so job. If baby is less than 3 months, follow the from Minnesota guidelines. Where am I? And you just follow everything according to the algorithm, and nobody will prove you wrong. Protocols. There are protocols. Like you are about to say something, and the team will say, "Oh, you know what? This is not our protocol." Where am I in the whole picture? I have spent 4 years in medical school, and you are not really having a respect for me. Then the other two, revenues and quality metrics. This I'm going to touch base a little bit so that you guys, when you are about to graduate or those who are negotiating the contract, you know how to negotiate it. Okay, this is very important, and that's part of your relevance. If you don't make yourself relevant, trust me, the system will eat you like crazy, and you will be just a part in the whole mechanism. You don't want that. Okay, so that's why quality metrics come into, revenues come into. So what is let's go back to practice-based learning. So what is the important? Like nobody teaches you how your whatever you are doing has some impact in terms of quality. Like suppose if you are treating an infection in the leg and you keep the patient for 10 days and the other physician discharge the patient after 7 days. So the hospital will say, how come this guy is doing great, and he's saving 3 days on us, 3 days on insurance. What is that? So you said, you know what, look at my readmission. I never readmit, and it's 50% of the patient get readmitted because I think antibiotics should be given for 10 days. So these are quality metrics. Nobody teaches you about all these things. So I'm going to touch base a little bit on that. And then next is, what is the system-based practice? It's revenues and how insurance works. How many times we tell you to call for a concert and you don't know what happened beyond that. Why we are not only calling the concert for getting the information. Many times it's just because of the system. You want your consultants to be really getting enough patient so that they can justify their revenue. Don't tell that I'm telling you that, but this is a little bit part of the consults which we do. But otherwise, honestly, this time and age, you can manage DK on your own by looking at AI. You don't need an endocrinologist. Don't take me wrong. I'm just giving an example. Or you don't need a neonatologist for certain thing. People quote me that this guy specifically took on one specialty. Okay, so again, going back to the all four things. So I want to take the V out. I think we have to be relevant anyway, wherever we go. Otherwise, if you're not relevant, then it's really why, a robot can do whatever we are doing. So let's walk one by one. So I will start with guidelines. And this is something like I told you earlier that if we have guidelines, why should I think? Why should I rethink? Why I have to go to 4 years of medical school if somebody comes up with a guideline and I can just follow that? Why I have to do so you have to make yourself relevant. So let's say, for example, there are certain terms which are overlapping, like guidelines, protocol, policies. It's just like any company. If you have their mission policy, their mission statement, then they have their statement, then they have their CEO statement. So the idea is, which I want to give it to you guys, that guidelines are there to help you. They are not like, you can follow, you can reject, whatever. It's just like the analogy of like the airplanes have guidelines to board the passengers. Do I like it? No, I hate it. Whenever I get group 7, I hate it because I have to go through everybody. If I'm the aircraft manager, I will have the first class passengers last, honestly. Let them suffer. And you go through, you go there reading newspapers, somebody's an iPad, and what does your group 8? So these are guidelines. Somebody smart will change one day. They said, why don't we sit in order so that nobody will be late? You don't have to cross anyone. 38, 39, go first, 37, 35, and then the first one to go last. It's easy. You put the bags, all good. But they want to create this chaos, but these are guidelines. Or they will call it protocols or policies. Trust me, sir, this is our policy. You are prepared, you have to wait. So, but change it, try to change in medicine, okay? So the example is, this is a very busy slide just to tell you that how, like clinics have guidelines. A person walks in, like if you go for your yearly physical, you will have a vitals taken by someone, then you go wait, and they make it in a very marketing way so that you feel that you are taken care of. Although total time is 1 hour, and you say, God, I hate that. Like why it took 1 hour from my blood pressure to a physician, and to you, physician is chatting with somebody in the computer, although he's working. So what I mean to say that these guidelines and protocols are made to make system is smooth. If it's not working, we have to change it. And there is a room for us to be clinically relevant. Okay. Another one, this is, you guys all know about it, that how certain policies, certain protocols, and sometimes you feel like, God, if I have to look at all that, why not the artificial intelligence give me the final calculation? And I'll give you some examples of it. So this is taken from Dr. Pichilingo's presentation. I like it that even for UTI these days you have calculations. So if you don't want to overthink, just put your numbers in there. The machine will give you an output that, you know what, do this and you'll be done. So you're not, even patient have access to that so they can run and they can come with a diagnosis. Are you going to give me sulfonamides or you're going to give me ceftriaxone? Are you kidding me? You know already that. Okay, same thing with diabetic ketoacidosis. You guys all know about these protocols. What I'm coming to that, these guidelines are there not to really uproot you. It's there to help you as long as you know how to use it smartly. So how these guidelines are made? Nobody just wake up one morning and say, you know what, let's make a guideline. It has to be like in an organized way. There are certain organizations that gives you guidelines and you follow that. The quality guidelines comes from somewhere. Infection when COVID hit, you all remember what the guidelines are. You have to go get vaccinated, you have to follow mask policy, you have to do this. So you try to be clinically relevant there. You are proposing something to the machine that, you know what, you have fixed knowledge and I have variable knowledge and I'm giving you what I know. Okay. So take it. So now we are going to protocol. And as I said, that many things are overlapping. Like you can say, Dr. Madhu, this is not guideline, this is protocol. But I'm just telling you, these are there to help you. Let's see some protocols. For example, I'm an neonatologist. I work with babies. So, like for example, we have a protocol of admitting all infant of diabetic mother to an ICU. Is it the protocol everywhere? I don't know. Maybe not. Maybe it's an institutional. So you are clinically relevant. If you're working somewhere, you can say, you know what? Why you do that? You don't have to admit all infant of diabetic mother to the NICU. Second example, admit all less than 33 weeker to NICU because weight criteria. Again, this is probably an institutional protocol. Then retinopathy of prematurity, intraventricular hemorrhage, PDA, therapeutic hypothermia. So there are protocols. But look at the other side. What's the advantage of it? Like ROP, you don't have to think anything. The moment the patient is this age, the patient will get the ROP exam. You just write the orders are already populated, so it's helping you. The guidelines are helping you, it's still clinically relevant. It's not stealing from you your value. Basically, it's making your management much better because now things are being taken care by the AI for you. You just like hepatic hypothermia, there is already an order set. You just select that, everything will be populated. So to me, I think this is good that I can spend more time with families rather than working on the computer. Trust me, it's not lock them up. It's look them up. Okay, lock her up, lock her up. This is look them up. It's not a slogan of from an election. Don't take it. So now the hypoglycemia protocol. I think those who have worked in nursery knows about it. So again, if somebody like I have to call probably my senior for 35 years back and tell him or tell her about the sugar is 20, and then she will tell me, okay, then tell me this, tell me this, tell me this. And finally, after getting so much of time, she will tell me do this. I don't have to call anyone. I have this protocol. I can just follow, or I can tell my nurse that follow the protocol, repeat a sugar in 30 minutes after feeding, and then follow. Same thing with other protocols. See how different institutions have different colorful protocols. As long as you have that, it can help you. Trust me, you're still clinically relevant. The protocols are not stealing your knowledge or your value from you. Okay, so like I said, it's a variable spectrum. Like I said, protocols, guidelines, and policies, you can, shape whatever you want. And the thing which I want to say is institution really sit, they look at certain guidelines and they make it to protocols. And you can push in protocol. And I will show you an example, from a daily practice example that how somebody questioned it. And now people are saying, really, why should we do that? For example, NICU. Anybody can guess which is the policy and not a protocol from this list of 5? Or let me say, like parents rooming in. Do you think it's a policy, protocol, guideline? You have to do, everybody should get this, whoever, it's like a car wash, every car comes in, get the soap and tire wash, or parenting is in an elective thing. If it's an elective thing, probably it's a guideline. So again, let me reiterate, it's something you have to do on everyone, probably it's a policy or a protocol. For example, I have to do ROP screen or certain babies, it's like a protocol. I have to do any baby who is born before certain age or certain age, I have to do that. Car seat test, anybody who is delivered before 37 week, I have to do that. I cannot bypass that. So again, like hand wash. Anybody coming to NICU is like everybody here, irrespective. So these are the examples where, like incubator care. In nursery, you don't have to do incubator care to all babies. They are grown enough. They can tolerate all the temperature outside the incubator. So the idea on the right side of the box is telling you that it's honestly an overlap between guidelines, protocol, policies, but you have to make yourself relevant. And another example, now another word. See, every year they throw a word for physicians to really look at. Now they, instead of calling it clinical pathway, they call it clinical pathway. Person coming in chest pain, follow this clinical pathway. Troponin, draw this, draw lab, EKG, ST elevation, call cardiologist, cath lab, intervention, radio. Oh, you're like, the whole pathway is activated. It's just like complement pathway. You just hit one thing and everything is activated. See the pathway, my gosh, it's like where I am in this whole picture. If machine can do it, why you need me to teach? Why it take 4 years for me to learn? You can have 1 year of medical school and 3 years of artificial intelligence and I can learn. And we are not done yet. Now we have clinical decision support. Like you're writing an order and a window pops up. Do you really want it? Yes, I'm not a fool. I want it. But trust me, most of the time it's very good. Like other day when I was writing a TP and it was my first day after coming after holidays, and I wrote wrong because I did not realize that baby has 2 drips. And the window pop in, do you really want to complete the TPN? Baby has UAC, UBC running at 0.07. Thank you so much. I'm so sorry. Yes, please. I don't want that. So I corrected myself. So again, take it in your favor rather than, okay, so see, like this is the example. Now, I don't know if you guys know that now we have this add specimen. Suppose you have collected a blood on a baby this morning and you want to add another thing to it, you can just call and add. So that's a good thing. Instead of, like a fix, there's no fixed ideas. And this is the example which I said, which came to me that, do you really want it? You have still 2 orders there. And again, just a small joke to throw there. Okay, so this is the example which I was saying, that how car seat, whatever you call protocol, policy, but see what happens. We all know that American Academy recommend car seat for 37 people. These are guidelines. Now you said that, you know what, we will have a policy in our hospital because the academy is telling us something. We'll have all babies born less than 37 weeks should go through the car seat test. So you devise a procedure and protocol. You put a baby in the car seat. Of course, before starting that, you ask the mom to bring the car seat. You put the baby for a certain time, check their saturation. There's like a procedure to it. See how the guideline is becoming your institutional and now it's becoming like a procedure. Then you follow the pathway, clinical pathway. Baby fails, then repeat this. Another time, the baby pass, do that. So it becomes a path. And then if baby pass, baby fails, whatever you say. But guess what? Somebody challenged it. They said, why do we have to do that? So now not all centers are doing car seat test. And it's a nice paper if you get the time, pull it up. So now going to, again, like smart phrases. See, like this is the example which I was telling you. The system automatically types for you that get an ultrasound on day 3, day 7 to 8, and day 28. That's giving me a perfect guideline. Your orders can be built in that way. Once you order your first head ultrasound, it will automatically populate the second other one and you're done. So you don't have to remember that. So you're saving on your energy on this. So you are still relevant, okay? Okay, then again, like I said, you guys know most of the things here. For example, like this 3, 7, and 12, 24 has been changed now and people are talking about doing this. But again, we still follow that. I'm just saying that protocols are not words written in books or in cards somewhere, so you cannot change. You can change, you can adopt with the evidence, just keep on changing. So now we are done with the easy parts. Now quality metrics and revenues, which I think especially the students will relate to it, that how. So whenever I start, I'm given a topic, I said, let me search you and see what is available on net and see that how many talks are available. This is only one page. This is a screenshot for healthcare quality. You see my search, quality improvement in healthcare lectures. And this is just one screen. And I'm sure that if I have scrolled, it will be like half day will be gone. So there's so much available on internet. People are talking about healthcare and quality. So you cannot get away with that. If you think you can get away with that, see the next slide. If you're a student, you're interested in professional activities, they want you to know about quality in MS3 and MS4. So you think you are done if you become a resident? No, the ACGME wants to know about the the quality and all that metric. And you think you are done after this? No. If you are a physician, you still have to do a quality improvement thing. So learn it early, master it so that you have no problem. And that will help you becoming clinically relevant. I tell you, many things as a quality person, when you see that, you have a vision. Why this baby is staying more? Why I'm giving this IVIG at this time? Why I'm giving antibiotic for 8 days rather than 2 days? So these are certain things the machine will not tell you. This is just taken to give you an example. Don't confuse yourself. I'm just telling you, like many metrics we are watched, which you don't even know. Like you just come here, work, and then you go, but people are looking at your performances by different quality metrics. And again, like I said, don't complicate yourself. This the important part which I'm going to highlight. These are the part which I'm going to highlight here. So why it's important? Because you have taken an oath to do right to human, okay? But your health outcomes are not good. If you are in a practice where you have a lot of mortality, you should not be proud about that. So health outcomes. So in a sense, monitoring is not bad. Somebody's looking at you. I hate giving awards for everything, but I like the part of quality metrics. Like you should not be giving award, the best resident of the best of the month, best employee of the year, best employee of the day, best employee of the minute. I don't like that. But health outcomes does matter to me, and I think should be. Clinical processes, like for example, there should not be much variability among different physicians. Like residents don't have to wait for so and so attending to come and they can enjoy the rotation. It should be like a global phenomenon that everybody is there to teach, learn together, and that we have a nice clinical process which will ultimately bring quality to our practice. Patient safety. This you all know that how many accidents happened. I don't know if you guys remember a few years back, the heparin dose was given 10 times to two twins and they died unfortunately with bleeding just because of the labeling was not right. So then they changed the some minor things, even the color code of the syringe can make a big difference. Like for example, there was an accident of infusing intralipid as taken as a breast milk. So now they have changed the tube to different color. So and different, you cannot even put it there. It's called human factor engineering. We all have errors, but if you engineer it not right, you can have a safe care. Then efficient use of resources. Like for example, you're calling and my residents see it all the time. They call for routine C-section and they are there for like 10 minutes, even the anesthesia is not there. This is waste of your expertise. I'm clinically relevant. Don't please waste my time. Call me once then I'm in-house, so I can just run and come here. Or surgeons, if they are scrubbed already and something is not ready, it's waste of their time. Care coordination. This is the main problem here. Like big example of NICU and nursing. Many times reciprocally, when we transfer baby, we never coordinate the care honestly. And they get the admission and they are busy and they said, what is this? Nobody told me about that. Same thing when you're discharging. It's good to give a call. I know in our setup, we have a very different clientele, but in private practice, many times the hospitalists do call the private group, even the clerk and telling that I'm discharging your patient and we did this, please make a note of it. And you guys can go back to the computer, log in and see what was done. So care coordination is a quality metric. Then, and you guys know how important in this current world is patient engagement. Like years back, nobody would have thought that patient can even read your notes. Like if they're reading, you're hiding from why you're reading the note, it's my thing. So now it's no more mine, it's yours. You can read. It's basically the CARE Act if you're hiding, you are breaking the law. They should have, until unless it's something you don't want them to see it right away, like STD reports, you want to talk to them personally, and you don't want it to be released on the internet or your electronic chart. But they have access to it. You want them to be engaged in the care. I know the people from medicine, they know how difficult to engage a 40-year-old chronic alcoholic to leave alcohol is very difficult. We work with pediatrics, we are much better. And then going back to, this is very important concept of having patients' perception of their care. Like I'll be honest with you, when I did my MPH, my research paper or thesis was updating mother within an hour. And I said, this should be routine. So I went to a mother at 9 a.m. I'm an attending. I have luxury to come late. So I went to her. I said, oh, so do you know about your baby? She said, no, nobody told me. What time the baby was born? 6 p.m. It was an infant of diabetic mother. But again, from 6 p.m. to 9, the mother, because probably she went to bed and she has a C-section. I'm not like defending, but what I'm saying, look at the flaw in the system. But that gave me an opportunity. There was some opportunity for me to work. So then, how it happens, I develop a protocol and then we decrease that time. And finally, we brought it down to a very nice time, I think within 30 minutes, and we published that paper. So perception of care is very important, especially in adult medicine. And population and public health, we all know that how state and federal government, they look at whatever you do has to have an impact. Okay, otherwise, if you are just working in silo, that's not going to the thing. So now I know this 7 or 8 things are important, so I am spending more time on that. So like I said, mortality. If you're not decreasing on mortality, you're not making a difference. Length of stay, I gave you example already that how come your patient goes early. And so length of stay is a big thing. Okay, they measure it. Readmits, like I gave you example how, so you should trade. You're discharging early, but you're readmitting them back. So you're not gaining there. Near misses for patient safety. Anybody know what near misses from students? Suppose I'm an intern and I come and I prescribe. Let's say I said, it's actually a event happened to us that we were really almost coding somebody. The baby was very in distress, and the cardiologist said, "Okay, order propranolol," and the resident ordered propofol. So I was at the bedside and they were mixing it. I said, "How come you have this white liquid? Propranolol is not white." Oh, they said, "It's not, it's a propofol. Pharmacy dispenses propofol." I said, "No, please don't give propofol. The baby will be really." So we picked it up. It was a so that's near miss. So if you see how you are becoming clinically relevant, like the system has dispensed it. Pharmacy got an order, the system dispensed it. Okay, order is given, but you are there. You say, no, that's not, please don't give that thing. But again, knowledge is important. Then cost. If you're very costly, I don't want to give the analogy of Apple phones, but Apple phones are costly, but there is quality to it. So see, everything has, but it has to be balanced. Like Android can compete, and if they bring the cost down with all the features, people will go for Android. So same thing. If your hospital is very costly or your care is very costly, why should I get the same care across the street? And you guys know already about customer assessment. And I'll show you the next slide. And those who haven't seen it will be shocked by looking at how you are evaluated. Even the parking satisfaction evaluate your practice. If I don't have enough parking, you're not a good physician. Or not good physician, but your practice is not providing me this. I remember somebody telling me a story that a person post-cath asked for a sandwich, and the nurse said, "No, let's wait. You are clear died." And he wrote a very bad thing that I didn't get a sandwich when I asked him. Yes, sir, but you just the cat can wait like a day to eat your sandwich. But these are unfortunate. Whoever developed it, because we were not involved. My purpose of doing this talk is honestly, don't be a sideliner in medicine. Unfortunately, we were never treated like that. We are the part of the team. People come and dictate, this is the way you do. One person has to stand one day and say, "No, sir, this is not the way," just like the car seat. No, this is not the way. This is not the only way to do things. There are many ways to do things. So you don't have to know all these companies and how they run, but just to run you the list, like cleanness of the facility, comfort of waiting area, convenience of parking. And guess what, sir? I have no control on that. I also, like those who are from LSU, you guys from LSU, you know how far you have to park sometime to get to your LSU building? And parking, my gosh, you have to go through all there and then go there. Now you guys have resident parking, and this facility does have good parking. But when we were there, trust me, it was a pain. One day I remember I don't get a parking in the faculty thing, and it was raining, and I still have to go and imagine I'm spending extra time and people are evaluating me on that rather than they are complaining. I'm not saying it's not the good thing to have. When you design a building, make sure, see yourself as a patient. I want a good parking, but your practice should not be evaluated. There should be some other area to evaluate that you practice this side rather than impact on the practice. That's not medicine. Another example, see, would you recommend this hospital? Time physician spent with you. Like we teach you to be nice to patient, communicate, and I give you only 20 minutes per patient because you will not, your revenues, you have to see 20 patients to generate enough revenue. Give me one target, don't give me two. Like you're giving me 20 patients plus 20 minutes, what? Some patient might need 30 minutes. And again, there are different, grade to follow. And this is the example of the grade. And I don't want to again go, my point was, which I want to convey, I think is conveyed already, that You will be evaluated. I'm being evaluated on things which I have no control on. Is it fair? I think not. Somebody has to say something about it. And then again, you see how friendly, like sometime I remember my wife changing her OB just because the clerk was to her was so obnoxious. But the physician was nice. Poor physician doesn't even know that my clerk. So I said, did you call her and tell her that? No, I want to change my physician. See how different things impact your practice. So clinical relevance is not only you. There's so many things that really, it's like a Venn diagram really hitting in and making. And again, performance, there's so many dynamics we are being watched. I'm being questioned by my chair, I'm being questioned by my nurse, by my patient, by my family, so many things. Anyway, now the last part, revenues. I know that this word RVU and all that. So earlier, long back, it was easy. You go to a physician, he or she sees you, you pay the practice, and you put the money in the pocket, you go home. But now there's so many controlling factors, like your practice is being calibrated or measured by different factors. Finally, you get to the unit, and unit is multiplied into dollars. God help us. Like I just need to know. Even when you see your bill, like my dental plan came through, and trust me, after 5 page, last thing they wrote, you don't owe anything. Thank you, sir. You could have told me on the first line. I don't have to see like X-ray 405, this 201, this thing is covered, this thing is not covered, but you have a separate plan, so that covered it. We are making it very complicated. So there are certain ways, again, I don't want to, like I said, I just want to throw the idea so that, when you go market yourself after 4th year, you should know what you're dealing with. You want to be clinically relevant. You're not a machine, okay? You're not buying a machine that will work for you and just generate money, okay? So for example, there are different codes, and you know what codes are. Like for everything you see, there's a code. Then for code, you multiply by the number and you get finally some number there. Then you multiply and convert it to dollars. And this is the way you convert it. And again, like I said, I don't want to bore you with all that. So finally, you got this much amount. And they give you a target. For example, for me, the target is 10,000 every month. I have to generate that. And if I'm generating 11, 12, they will compensate. If I'm generating 9,000, they will say, you know what, this month. So on an average, I'll be okay. So when you guys negotiate a contract, which is RUE based, make sure that your practice has enough patients, especially when you're coming out and joining a community hospital. Get a protected contract. Don't sign for RUE right away. Say that, I want a protected compensation for this, and after 2 years, I can change it. Because by that time, you will have an idea what practice is this. Is it worth it really? Would I be seeing 20 patients a day to justify? And then tasting, that's why what happened. Those who go to primary practice hospitals for 3 years, they don't want to come to fellowship because they have tasted 200K and now they cannot come back and work for 50K. So it's very difficult to go back and compromise. So make sure that you negotiate that. So again, we are clinically relevant. We are making our point that, sir, we are not machines, okay? So now I think we are done with all this. So now let's go through, we'll quickly skim through certain slides just to make sure you understand the value of machine and human. We are human and we should be treated as human. Machine can do your job, sir. I'm not saying machine cannot do. Like a cashier, you can replace, a teller, you can replace. At airport, you can replace the person. But physicians, I think they're not there yet. Remember my first slide that you can just go in front of a machine and then otoscope comes out, put it there, stethoscope comes out, and the prescription just come out and you go and get your prescription. I think we're not there yet because we are dealing with humans. So how to become, actually the right question is, okay, Dr. Manzar, so far you wasted our half an hour just telling us that we have this. So how can we be clinically relevant? Are you going to give some remedies or giving us some tips? So this is like a double-blinded study. Neither the attending knows, nor the residents know. So double-blinded presentation. I'm also learning, but I think I will give you some certain tips which I think you guys can work on. This is from a recent Olympic, and I like it honestly, especially my generation. So for me to get to first place in 1998, look at the criteria and look at this guy. He scored better than that, and he was the last person. So you guys are entering into the world which is very challenging. We were so blessed. Like I said, talk to family, they pay you, they pay your secretary, you keep the money, you go home. Now there are so many things. The quality metrics are changing every year. So now like this guy, 9.92 second and it was first, and this guy 9.91 second and he was last. How come the parameter hasn't changed? But look at the competition, my gosh. Like MLEs, you score 77, 77, you get to best program in pediatrics. Now you score like 99 and something, you still don't get introduced. So it's all competition, honestly. So, but you have to compete. So you have to make yourself clinically relevant. When the CV comes, they will have all the thing, observership, letter of reference, but something has to really come out of it, which you have to work how to make that happen. So see, targets are changing. So what was excellent yesterday, unfortunately, maybe not good enough today. So as long as you know that uh, ignorance is bliss, but not at every place. You know, you knowing what you're dealing with is really, really important. So now let's skim through some slides. See how I don't want this is from internet, so I did not create this encyclopedia thing, but people used to have. My father used to have a collection of encyclopedia and proud about it. I have all the sequence, the drawing room. You have the match to the curtain, and he was so proud of this encyclopedia thing. But now with Google, nobody cares about it. Same thing. I don't know. Maybe people in US haven't seen it, but this is a mobile phone which is very popular in developing countries. That's why you carry it. Nobody really uh, have to do that. So you have to change yourself with time. Like you know, when you used to go on the aircraft, there's a magazine. You take it out, flip it, same information every time. You get bored, but now you have Wi-Fi on the aircraft. See how they are changing too. They said that this is old-fashioned stuff. So now let's see AI in healthcare. And for 10 slides, I will just go fast, just to give you an idea how like AI should be in your favor. Okay. And you cannot get away. Just like the quality thing, you cannot get away. It's required as a student, as a resident, as an attending, whatever you do, same thing with the AI. Use it to your favor. We use in life, we use it. I don't know why you're so scared. I see my younger generation, they're so scared with AI and medicine. Why you're scared, if a machine can room it for you or clean the room for you, just advise, time it, and go. Like, why do you have to really do it manually and strain? Also, you guys already know about how this Copilot works. You do any search, it will just spit out whatever you want. And you guys know about ChatGPT, how it's coming along. This is a certain example that I commanded to create an like a template for clerkship, and it just given me all the guidelines. How can I do that? They are creating questions from AI. I know this picture, anybody can diagnose. But again, that's how teachers are using in their favor as well. Then I created a question. I asked the AI that this is the question. What do you guys think what the answer is? And AI not only gave me the answer, but it gave me the right explanation, honestly, that why this A positive, B positive. So my question at this juncture is, why you're asking me question which an AI can answer? Why you're not asking me question which really is very relevant to me? If I am at the education center, I can just do 50-50 to start with, because certain questions are recall. Like in my practice, if I have a 12-year-old, I will see what vaccination this girl or boy needs. I don't have to memorize and then or a patient comes to you, he's holding your tie and he's going, baby, bye bye. What's the age of the baby? You know, I will probably do the developmental printed screen and just tab it, and then it will come to me. Use me for certain things which is very important. Same thing. You guys know how you can even generate. So I said, I said, let me make a presentation for Ninato John this. Just advise that. And the system did it for me. I just copied it on it. See, it created 5 slides for me. Oh, see, it created 5 slides. You can command whatever. So it's a 12 or 13 page article. And I told AI to read it for me. The AI read it for me. Simple. I don't have to read through every line. It gives me the whole synopsis, saving my time. Am I critically relevant? Am I losing my skill to read a paper? No, I'm the one driving the car. The car is just automated. But I am controlling it, whatever remote I have. It's like a drone. I'm running the drone. Again, same thing. It summarizes everything. Even for if you submit paper these days, they ask you, do you use AI or not? Even on Instagram, if you post, they ask, are you using it just for the copyright purposes? Certain examples in those who are going to join office practices. Really, your job is going to be use it. Like instead of dictating the summary, now there are application available. You just put in the room, you talk to the family. When you go out, the system records everything. It's translated to EHR. The whole conversation is recorded, and so you don't have to go back and type. It's all done. So many tasks can be done by the computers. Again, like I said, I'll skim through just to give you a concept. And I think this is the program which is describing for you while you're even talking to the family. You don't need a physical person or, a pre-medical person who wants something on the CV and she or he is really working hard and pleasing this physician to get some reference letter that I'm a good scribe. Okay, so now again, how AI is helping us becoming more relevant, but it's helping us in diagnosis. For example, like ECG, you know, you guys all know that when the ECG or EKG comes on the top, it has already read for you tachycardia or no. It's all system is reading it for you. You just have to correlate with X-rays. Actually, recently X-rays AIs are performing better than the radiologist. And the other day, we have a case where a baby was getting the barium swallow and the nurse was holding the knee. So the X-ray was taken and the radiologist read knee as chronic degenerative changes on neonatal knee because he was seeing all that bone. So I took a picture and sent to my resident. They laughed at it. So sometimes they do read. Like yesterday, I read a lead was going this way on the baby's chest, and they read it as pleural effusion. And if you follow the lead, it goes all the way. It's just the lead that is going and giving like a little bit of, a shade there. So again, artificial intelligence is there, but I'm still clinically relevant because I know how to. But again, I'm not denying that. If system is giving you something which is handy, why not? For example, neonatal sepsis calculator. And again, those who has rotated through NICU, they know that how it's very important in every delivery note. And honestly, that has made a big difference. So this app, which is like AI based, is you don't have to think now. Otherwise, I have like same analogy which I give. I have to call my attending, and he or she guides me through the whole thing. The system will guide you through. And in coming years, the Epic will take all the information, and you don't even have to put all these informations. Like Epic knows where the boom's temperature is, where the baby's fever is. It should just honestly, it should be popping up. Just like many scores in adult side are given on the right side of the screen, they know what is mSOFI score on this patient. It's automatically calculated. So like this, we do it manually, but this will be hopefully same thing with the bilirubin. Fortunately, Epic has a great bilirubin, management plan. It gives you put a cursor there. Many people don't know it, but if you put a cursor on the spot, it gives you everything what you need. How far are you from exchange? What is the phototherapy thing? What is the risk factors? So many things are already built in. So again, use it. I'm relevant. I'm making the decision. Machine is just helping me. I don't have to pull the manual graph, spot it there, and say, oh, you know what, we need phototherapy. Machine is giving you that. And there is another, people are coming out with gadgets. This New Predicts is a company that sell the program that I can tell you when the baby can have phototherapy or not. Is it safe to save the baby? Send baby. And again, clinical decision support, like I gave you already example, when you put an order, the system reads it and say, you know what, there is already an order for LASIK. Do you really want it? We just sorry, it's a mistake. I was on a wrong patient. And many, this like near miss. So this is the example which I was telling you. See how this was given, mSOFI score, basing on all the thing, and you can make a decision basing on that. So again, the syphilis guidelines is there. I hope somebody one day will make it easy for us. Just put some numbers, and you don't have to get into probable, possible, okay, no, like 4 types of syphilis are there. So it will just give me, sir, tell me what to do. I don't have time to go through all the algorithm and read between the lines. Just tell me, help me with that. So AI rule is there. You guys probably have seen, unfortunately, Apple was not great with this marketing, this virtual tool. I think it came and it went. Nobody liked it. So, but there are newborn resuscitation, gadgets available. So what people have, I have seen this YouTube, but basically it's like you put it there and you really feel everything like it's happening. Like you see the baby's vocal cord, you are virtually there, honestly looking at it. So you can use AI in your favor. But again, there are some ethical dilemma because whatever is garbage in garbage. So if AI was not trained on diversity, you will not get the diverse answer, honestly. Like, if like in Abu Dhabi now, they have a brand new airport. You just walk in through the gates. Nobody stops. There's no passport control, nothing there. They read it. But people are saying that they might have this later on some problems with certain races because it was not tuned or so they are looking into that. So what I'm saying, everything green does not mean it's green. Okay. So this is the example. I think I pulled it for you guys. See the knee thing, the hand, the nurse is holding it and what they read. Mild degenerative disease on baby's knee. So please, please, please be all clinically relevant. And I'm not saying maybe this was AI generated. I don't know who read it. Maybe the AI machine saw that and they saw some change in the knee and they read it that way. Again, let's conclude that You want to remain? So we started with, are we clinically relevant? Then we said, should we be? Now we are coming to the conclusion. These are the some tips which I'm going to give it to you. One thing which AI is still like, there are robotic surgeries going on, but develop your skill, especially for pediatricians. Develop your umbilical catheter line. You all guys can learn when you rotate through our NICU, honestly, because we are not there yet where a robot can come and put a UVC. UVC is a 3-minute thing. You can learn it, and that will make you relevant. The companies will want you, or you know what, we need this physician, because nobody can do UVCs for us. So see, one point. Second point, communication. Robotic communications are, I hate when you are on the phone and it's a system running. Thank you for calling. You are our first customer. Please hang up. If you're calling for this, try 911. I hate that. You want a person at the other end. Same thing, parents do want person at the other end. They should, so you want to be relevant. So work on this skill. I'm still working on it. So work on how to communicate, how to make them feel. No mother really wants to deliver a baby at 24 weeks, okay? Just walk them through this tough journey together, and they will start liking the, sometimes they make friends, honest. They are Facebook's friends. They go, the baby graduate, they are friends just because of good communication. Especially I give credit to my nurses, really. They do a great job, but I think as physicians, we have to really work hard on it. For two reasons. Once we are asked to do too much, like 20 minutes and 20 patient analogy, I think that's too much. I don't have really, and then I have to document things. I'm not listening. I'm not honest with the patient. And I have seen that. Like sometimes, oh, yeah, I understand that. Yes, you're worried about the next patient. God, and I have to go back to NICU because Dr. Manzar is already screaming, where are you? You have only up to 12 o'clock. Come in the afternoon and do your notes. And remain passionate. That's very important. And show some compassion and just bring human factor back to healthcare. Unfortunately, like I said, you walk into a system for your annual healthcare and nobody treats you as a human. You are just a revenue generating person or a commodity for practices, which is sad really. And I have seen it from other side as well. When I go as a patient, I see I'm treated like sometimes there's no human factor. Person walks in, like I remember one ER nurse taught me a very nice trick. I said, how you remember every time that patient comes? She said, see in the chart, I write that the grandmother was having some birthday or something. So next time she asks, how was the birthday? And then, so yeah, it becomes, I know I'm asking for too much, but trust me, as a group, if we can just, make sure that we bring it day to day small, I know we are busy. If you want to be clinical, otherwise, trust me, one day, like it will be a self checkout. You go self check in, and it will be self checkout. But what will happen? It can happen. But again, if you put yourself clinically relevant, the system will say, no, it's not working. Let's bring the physicians back. We don't want dissatisfied families. We want satisfaction there. So work on it. Again, just to make sure, you always have to use PowerPoint to make it bold, and work as a team. Again, it's very important. Nobody can work alone. I haven't seen anybody succeed. Uh, Even writing a rectal biopsy case, you need a team to write it, isn't it? Are you okay? Okay. So again, this is the website for American Academy. They have nice videos there. If you guys have time, I know with residency and clerkship, you don't have much time, but there are resources where they teach you how to use artificial intelligence in your favor, and you can just learn from it. And common sense is very important. And I have to advertise that I do have an Instagram channel, thanks to Gabby, and I do have a unit, NICU, and the videos are 522 in 6 months. So I'm excelling there. Any questions? No? Any questions from my audience remotely? So either things were clear or things just went out there. Okay, thank you so much, everyone. Okay, have a good.